Welcome back. This is the second part of a pair of podcasts looking at research design considerations. Last podcast, we took an overarching view of types of research, and in this podcast, we'll take a very brief look at some of the common experimental designs that are employed to answer research questions. Be aware that there are whole courses devoted to this topic, so this podcast will not answer any and every design-related question that you may encounter. As we talked about in the Question Refining podcast, a well-constructed question will help dictate the type of study design that is best employed to answer it. That said, there may well be several viable options. So the second step is to consider what you have to work with. If your patient characteristic is uncommon, a prospective study may take 20 years to gain adequate data. Similarly, if it is unethical to randomize patients to receive less than standard of care treatment, an RCT is not going to be an option, no matter how much you want it to be. The best that you can do is to choose the most robust design that still fits within your resource and ethical constraints and effectively answers your question. A case series study is usually structured to describe a group of subjects with a common condition or common intervention. A well-known example of this is a chart review. While usually retrospective in nature, it could in principle be used prospectively. For example, if you're designing a new surgical technique and want to know if it's effective at all, you might measure a before and after outcome for a small group of patients. An example question that lends itself well to a case series would be, what is the recurrence rate of anterior shoulder dislocation in Surgeon X's practice over the past 5 years with a standard arthroscopic Bankart repair technique? One can review records to identify the appropriate patients and then determine the recurrence rate. There are advantages and disadvantages to this type of study. First, it's easy and inexpensive. It's good for uncommon conditions because you can review records as far back as you like. And it gives at least some indication of treatment effectiveness, even though it's not as robust a design as others will come to. Some disadvantages include the potential for poor quality records, the often retrospective design, and a high potential for bias. A case series may serve as a launching pad for design of better quality studies, and so there's definitely a role for this type of work. It may also be the only reasonable design for the very uncommon conditions or procedures. It has a key role in QA/QI work as well. This type of study is somewhat more robust than a case series, and delivers a different sort of information. The basic premise is that you're starting with the disease or condition and trying to identify a risk factor or exposure that led to development of the disease. For example, you could take a group of patients with non-unions of their midshaft clavicle fractures and compare them to a group who united their clavicle fractures, and then assess whether the non-union group had a higher rate of our exposure of interest, in this case, smoking marijuana. In this design, it may be helpful to try to match the controls to the case patients in as many ways as possible other than the exposure of interest. This observational design can be done in a short time because you're working with a snapshot. It is particularly useful for studying rare diseases or conditions because you deliberately set out to capture cases with confirmed disease. On the other hand, it may or may not be able to prove causation, but will at least help prove association. It also doesn't give you a larger population metrics such as incidence. There is also the potential for bias. This design is almost the reverse of a case control design. With cohorts, you're taking a group with a risk factor or exposure and following them to determine whether they develop the outcome of interest. These can be retrospective or prospective. An example of a single group cohort study would be a registry-based study. In principle, a study looking at patients with a particular condition in which some get treatment A and others get treatment B would also be an example of a cohort study. Differentiating this type of work from a case control study is sometimes murky. Our original clavicle question from the earlier podcast could be answered with a prospective cohort design if we leave choice of operative versus non-operative treatment of the clavicle fractures in regular marijuana users up to surgeon and patient choice. We would then look at radiographic data to determine how long union takes to achieve in each group. Advantages of cohort studies include being able to prove causation and being able to get population metrics. Large number of patients can be studied with fairly robust conclusions. The design may also provide a way to do reasonably robust work in situations where a randomized trial is either not feasible or not ethical. Downsides include the potential to need large numbers or long periods of time, making it suboptimal for rare diseases. It's also still very susceptible to confounders. In our example, what if we fail to take cigarette smoking into account? If the marijuana users in our cohort also had a high rate of comorbid cigarette smoking, an already recognized risk factor for delayed or non-union, this could provide an erroneous conclusion that marijuana use leads to increased time to clavicle union. Whereas all the previous designs are classed as observational, an RCT is experimental. We take a group of patients in need of treatment and randomly allocate them to either the intervention or a control group. An RCT can be single-blinded, double-blinded, or unblinded depending on the nature of the intervention. For example, our clavicle study could be done as an unblinded RCT. The surgeon, the patient, and the radiographic assessor would all know which arm the patient was in, ORIF versus non-op. An example of a single-blinded study would be one that looks at use of a graft jacket to supplement mini-open rotator cuff repairs. The surgeon would know which arm the patient is in, but neither the patient nor the assessor would be able to tell. Finally, an example of a double-blinded study would be our local ketotifen trial in prevention of elbow contracture. Patients are randomized to receive either placebo or ketotifen formulated in identical pills in containers identified by study ID only. Nobody knows which arm the patient is in. The major advantages of RCTs is the ability to minimize a lot of bias. Choice of treatment is no longer subject to selection bias of patient or surgeon, and potential confounders become equally distributed between treatment groups. However, there are clear downsides. It's difficult to do this type of study well, and it's often expensive and time-consuming. By the time you get your answer, practices may have changed, making the results less applicable. It's also impractical for rare conditions or uncommon procedures. The need for very specific inclusion and exclusion criteria can limit generalizability in some cases. It's still possible to introduce bias by manipulating who gets recruited. This is why it's important to screen all eligible people, whether they enroll or not, to monitor whether there are differences between the group in the study and its intended population. Finally, it is not ethical to do RCTs in some situations, and this is particularly true in surgical research. Regardless of your choice of design, the need to correctly define your control group is critical. In fact, you may need experimental design advice or guidance from a mentor to get this right. A badly chosen control can render your work meaningless. An example of this can be seen with considering use of collagenase to treat Dupuytren's disease. The manufacturer may want to compare the collagenase with open palmar fasciectomy, a highly morbid procedure, instead of needle fasciotomy, the procedure that would most likely be the competing choice. Going head-to-head with the open procedure may have painted the collagenase in a more favorable light compared with the fasciotomy. And it still won't answer the question of whether it's better than the needle fasciotomy. You may need to define what standard of care is. In some designs, a patient can act as their own control, which is a powerful tool when looking at a complex system. Crossover designs, which are admittedly easier to do with medical trials than surgical trials, can provide interesting control group considerations. Sometimes it will seem attractive to compare your intervention group to a historical control. This may weaken your design because practices can shift over time. Another important issue that spans choice of design is the choice of who your sample group will include or exclude. You must clearly state your specific criteria so that the reader can determine the applicability of your work to his or her patients. If you set your criteria too narrowly, it will limit the applicability of your work. If you set them too broadly, it may be difficult to glean important conclusions. Lastly, depending on who you're including or excluding and for what reasons, you may run into ethical concerns to navigate. This can include doing work in vulnerable populations, such as children, the elderly, those with cognitive or physical impairments, or First Nations groups, or excluding people based on language usage or print literacy. Please remember that study design is a field in itself, and this podcast won't even begin to touch on all the issues. Recognize your limitations and ask for advice when you need to. To sum up, study design is a highly nuanced field and is an important step to harness appropriate expertise for. Designs come in a number of flavors, and some will serve your questions better than others. In setting your study up, careful attention to control groups and eligibility criteria is vital to creating a valid and applicable study. Up next, we're going to take a closer look at vetting our brilliant idea for real-world considerations.